Thank you, and hello everyone, and thank you for joining us for episode 3. Hopefully this will be exciting as episode 3 of Star Wars. So today's activity is titled COVID-19, Impact on Caring for Your Patients with Heme Malignancies. I'm Sagar Lonial, and I'm the Chief Medical Officer at the Winship Cancer Institute of Emory University. We hope that you will find this discussion to be both informative and educational. So at this time, I'd like to have my esteemed colleagues joining us today introduce themselves so you know who we are. We'll start with Carlos. You want to start off with intros?
Yes, welcome everybody. Carlos Del Rio, I'm a professor of medicine and infectious disease and global health here at Emory University, also where Dr. Lonial is, and happy to be with you.
Thank you, Carlos. Dr. Leonard?
Hi, I'm John Leonard. I'm a professor of medicine and senior associate dean at Weill Cornell and New York Presbyterian in New York, focusing in this context as a lymphoma clinician and clinical researcher.
All right, and last but not least, Dr. Roboz.
Hi, Gail Roboz, also from Weill Cornell and New York Presbyterian in New York City. I direct the clinical and the translational leukemia programs, and I'm here as a leukemia and MDS person for this webinar.
Thank you all, and I really appreciate this. And the following are disclosures, which are also probably available on the BioAscend webpage, should you like to see it. The webinar has been provided by BioAscend. BioAscend is an independent medical education company committed to supporting healthcare providers in their efforts to translate innovative science into clinical practice. Support for this webinar has been provided by Astellas. So let's get started. So it's been probably 3 months since when we first started meeting this way and talking about some of the important issues. And I feel like the world has turned itself upside down twice in that period of time. So Carlos, why don't we start with you? Do you want to give us sort of a current state of the art, if you will, on what we know, where we are, and probably more importantly, what we don't know about COVID-19?
So yes, happy to do that. Well, as you say, a lot of things have changed and a lot of things have remained the same. Globally, we have about over 7 million cases now of COVID and over 400,000 deaths. And interestingly, the epidemic now is actually growing the fastest in Latin America. And when you think about countries like Brazil, Peru, Mexico, Chile, Argentina, Colombia, in fact, 40% of the world deaths right now are actually happening in Latin America and the Caribbean. And Brazil is now the second country with the greatest number of cases, followed by Russia. The US, of course, continues to be the #1 country in the world by number of cases. And when you look at cases in the US, we have passed 2 million cases. And when you think about it, it was only late January when we had the first cases in the US. So really, it's amazing, as you say, the world has turned upside down. It really has, because we've gone from 0 to 2 million in 100 days, and we have over 100,000 deaths that have occurred in this country. Currently, we're seeing a very interesting epidemic in the U.S. because as we have opened many of the states and many of the we have relaxed our restrictions, we are seeing cases sort of plateau. We're not seeing, as a nation, either an increase or decrease, but we are seeing a decrease in number of deaths. Having said that, we're still seeing about 20,000 new cases per day in this country and about 1,000 deaths per day in this country, which, if you put the numbers in perspective, it really means that by the end of the summer, by late August, early September, we could be close to 200,000 deaths from COVID in this country if nothing changes, and that obviously is very concerning. We see in the U.S. Several patterns. We see roughly, about 21 or so states where the epidemic is maybe a little more than that, 26 or so states, where the epidemic is decreasing. And one of them is actually New York. New York really has seen a dramatic drop in the number of cases, number of deaths. And really, that was the epicenter of the epidemic. It's no more the epicenter. It really is no longer the epicenter. But we're seeing some states like ours, like Georgia, where the cases are pretty much flat. They're neither going up nor down, but we are seeing a slight decrease in hospitalizations. And then you see states where the cases are really going up. And I worry particularly about 3 big states. I worry about, it almost feels like the presidential election. You worry about 3 big states, California, Texas, and Florida. And those are the 3 states I worry about, because California, Texas, and Florida are 3 states where the cases are really starting to go up. And you worry about cities like LA, you worry about cities like Houston. In fact, Houston recently, I heard, is really having a lot of hospital beds saturated and having problems with that. So where are we in prevention and in treatment? Well, a lot of interesting things have occurred. A lot of publications have happened. Results of a clinical trial were first announced. Not the results of the clinical trial, the results of the DSMB were first announced at the White House in the Oval Office. I bet you've never had a drug in which the Oval Office announcement was where the first results of a study were done. But that's the era of COVID. That's where we find out a lot of our information. And we can say a couple of things. Number one is that remdesivir it is right now the only agent that has proven to have some efficacy in patients with COVID. It has not been, I tell people, it's not a home run, but it's a hit. Maybe it's a double, but it's at least a hit. We have shown that in people that have oxygen requirements that are in the hospital with severe COVID, starting them on remdesivir decreases the number of days they require oxygen, they require care, from about 15 days to about 11 days. And in the clinical trial, there was a trend toward improved survival in remdesivir, but this was not statistically significant. Patients that were intubated, patients that were in ventilators, patients that were in ECMO did not benefit from the drug. It's also, as a result of that, several trials are underway, and there's one very big trial called Act 2, in which remdesivir is being given to both arms, but we're using baricitinib as a way to immune modulate the inflammatory response, either randomizing by placebo or active drug. There are also there's more than 500 other clinical trials. I think one of them, drugs that has gotten a lot of attention, is hydroxychloroquine and chloroquine. The hydroxychloroquine and chloroquine data so far shows really no benefit on the drug in treatment, and there's some evidence of maybe some untoward side effects. So the stakes look more negative than positive. But we have to say that really there currently is no recommended preventative treatment for COVID-19. And there was a recent paper last week in New England Journal of Medicine showing that there was no benefit of using hydroxychloroquine as post-exposure prophylaxis in people that have been heavily exposed. Now, in the prevention arena, I'll finish up by saying that there's some very interesting progress in vaccines. And there's about 100 vaccines that started developing, and there's about 10 of them that are in clinical trials, and a couple of them have finished phase 1, are now in phase 2, and there's probably 4 vaccines that will be in phase 3 in the next couple of months. And between July and September, 4 major vaccine studies with about 30,000 participants each will be started, looking at 4 different vaccines. And the whole idea is really the way the vaccine progress has been accelerated, I've never seen before. We went from discovering a virus, cloning a virus, having the genetic sequence, to giving a first vaccine to humans in less than 65 days. I mean, that was just incredibly, incredibly fast. And what we need to do is be able to conduct this phase 3 trials to know about efficacy in such a way that hopefully by the end of the year, beginning of next year, we will be ready to start vaccinating individuals. And to do that, what the government has done through BARDA is using millions of dollars to start producing millions of doses of these 4 vaccines before we even know the results of the clinical trials. So if the clinical trials show efficacy, the vaccine will be ready to go. If the clinical trials show no efficacy, I guess the vaccine produced will be then discarded. But this is a big bet. This is a really big bet that we're all taking, saying, if any of those vaccines work, we're not going to start producing then. We will have the vaccine produced to start giving it right then. So that's pretty much the state of affairs today as it stands.
Thanks, Carlos. I'm going to ask you one more question before we get to our cancer colleagues from New York and get their views on this. And that is, I realize we're no longer going to have open access to the WHO reports, but the one that we saw yesterday suggested that there is no such thing as asymptomatic spreading. That does not speak consistently with what we've been told for the last 90 days. What are we missing?
Well, I think what was lost in the translation. I think what WHO was saying is that finding asymptomatic people through contact tracing is really hard because there's not many of them. I can tell you that when you look at all the data, there's probably around 3% of individuals infected with this virus who remain truly asymptomatic. The great majority of people go on to develop symptoms, some very mild, some very severe. But what we do know also is that in the 2 days prior to developing symptoms, what we now call the pre-symptomatic stage, people are highly infectious. And that has not gone away. Now, that person who is pre-symptomatic, when they're out there, you don't know if they're asymptomatic or not because they have no symptoms. Now, in 2 days, they may develop symptoms. But that's the reason why we need to be wearing masks all the time when we're in public, is really to prevent transmitting if we happen to be in that pre-symptomatic stage. And that pre-symptomatic transmission probably is responsible for about 40% of transmissions out there. Now, we learned a lot about transmission. The reality is that maybe 80% of infections come from about 20% of cases. And a lot of transmission occur in 2 settings, in 3 settings probably. Household contacts. So within the household, when you have a lot of contact with people, and this happens, for example, in churches, in nursing homes, in meatpacking places, in jails, and the other place that we're seeing we were seeing transmission. Some places have controlled it, but in other places we continue to see is in healthcare settings. So those are the areas of concern, and that's where we need to be focusing a lot of our attention, because that's really where we're seeing right now transmission. Now, that may change in the fall when colleges start opening and when people start getting together. But what we also have learned is that you need to be with somebody for about 15 minutes or so in order for transmission to occur. People need to realize that just because I walk by somebody in the street, that doesn't mean I'm going to get infected. It really doesn't happen that way. It's an infectious virus, but it does require a certain degree of close contact for transmission to occur. So as long as we continue practicing social distance, as long as we wear our mask when we're in public, as long as we continue washing our hands, I think we can really, really impact transmission to us and to our patients. And I think this is particularly important for patients with hematological malignancies.
Thanks, Carlos. Really helpful information. So, John and Gail, New York is coming out of its cave. What does reopening look like for you guys, sort of on a citywide level, before we start talking specifically about your subsets of patients with cancers?
Gail, do you want to start? Go ahead.
Oh, up to you. You can go.
Okay. Well, I would say, and I think the 3-part series that we've had together kind of, to some degree, fits in. I think the timing of the individual quote unquote episodes have really been as we were entering, as we were in the throes, and as we seem to be coming out. So I think it's a nice kind of flow of our discussions. You know, the state in particular has received guidance and instructions from the government that we can start to enter phases of reopening or renewing, so to speak. That obviously, as in other parts of the country, has intersected with some of the social activities that have gone on and demonstrations and marching and other things, which is a whole nother dimension, not our focus, but I think is a very interesting and important interplay. And I think how all of that affects what we're going to see in the coming weeks, we obviously hope it's not going to be a problem, but certainly have some concerns. I would say that in general, New York, as in some but not all other cities, the population of people largely, I think, has been very accepting and largely very mindful of social distancing, of wearing masks and other things. And so in some ways that has made it easier for our patient population, because I think when, you know, we tell people to distance, to wear masks, to stay in, to minimize contact, I think, you know, our patients are largely doing what many people in the population have been doing, and I think are pretty accepting of. I'll turn it to Gail in a second. I would say that our center is also kind of renewing and reopening, and to paint in very broad brushes, I think that we're now, just this week, we're now performing elective procedures. There are still some very strict guidance and procedures as far as what one has to do to schedule and to permit elective surgical procedures, endoscopies, et cetera, et cetera. And I think as a medical center, one way of thinking about it is that we are, for our non-urgent / emergent activities, as we get back to our normal day-to-day activities, we're kind of in the 25 to 50% range of our usual activities. And I think that is a rough way of saying it from the perspective of elective procedures, bringing back many of our outpatient visits, and so on. I think that we are looking to have a capacity in the range of a quarter to half of our activities. And what that has allowed us to do in areas unlike leukemia, where the patient volumes have been higher and the ability to do video visits may be less, in an area like lymphoma, where we've been able to do video visits and remote visits, we're kind of moving toward, I would say, again, 25 to 50% of our visits are now evolving into going back to inpatient or in-person visits. The density of our waiting rooms is kind of in that way. And I think our clinical staff, as well as research and education staff being in an academic center, is moving back to, again, not 100% capacity, 100% activity, but probably in the 25% to 50% ranges, to paint in broad brushes. So Gail, I'll let you comment as well, and then maybe we can come back to some of the details of this.
Well, so, I mean, I'm a Manhattan girl. I live here. I love this city. I have always referred to it as the epicenter of everything, and this was one specific area where I wasn't that thrilled to be in the epicenter. So I'm certainly happy that things are better for us. I'm happy for our patients. I'm happy for the city, and things seem to be going in the right direction. But I would say the word that comes mostly to mind is confusing. It's really confusing, because we went from, okay, well, this kind of is the flu, to, oh, this is not the flu, to, oh my God, we have pop-up hospitals in the middle of Central Park, to, is this the flu, to, now what do we do? And I think the problem is that it's very clear that declaring something unsafe is in many ways actually more straightforward than declaring something safe. And we managed lockdown. Lockdown has tremendous, tremendous implications that have been heartbreaking for many of our patients. I mean, if you are an affluent patient with a job that allows you to work on your laptop in a suburban home, that is just a very, very different experience from what many of our patients have had in less fortunate circumstances. So lockdown has been brutal for many patients and families. And in addition to that, it's really hard to figure out how to unlock down. And I can tell you, just for myself, I can't figure out. I think the things that's been most profound for me, I honestly never imagined running out of masks. I grew up here. I grew up with Western medicine. I never imagined that there would be a cart outside of a room that I didn't have a mask on. And now, how many days can I use it? Is this strap too tight? Does this thing fit? It's hard. It's hard personally to figure out what you're going to do for your own PPE. How do you protect patients? And if I can't figure this out for myself, how do I answer questions for patients? So I would characterize the current scene as, on the one hand, we're so happy that we're not talking about filling up hospital beds and ventilators in every bathroom. We're so happy about that. But the patients have micro questions, not only macro questions. And can I go to the wedding? Can I get on a plane? Can I take the subway? Because I have to take the subway, because otherwise I can't get to your center. And I actually, as someone who really, I went into a very, very small area so that I could really feel like an expert and really feel like I know what I'm talking about. And it's really hard to actually not feel like you can give more than kind of really good common sense and really good today's newspaper answers for people. So I would say this period of unlocking down is in some ways psychologically and operationally as brutal as it was to lock down, because people can't figure out what to do. My last comment is that whimsical rules are hard, and we have a lot going on societally that's very difficult right now, but whimsy is difficult. And to say that, well, you can go to the beach, but you can only stand on one leg. And if you're holding a ball, you can't throw it. But if you're throwing the ball, you can't catch it. These are incomprehensible rules. And the reason they're happening is because we don't have enough data, and that's absolutely true. But people can't follow incomprehensible rules. And I think that's causing a lot of stress just on all of us to try to figure out what makes sense, what doesn't make sense, and how do you color within the lines and not actually break a rule just because it makes no sense.
Yeah, no, I think you're putting a voice to what I think a lot of people are experiencing. And I can tell you, certainly in Georgia, where we're, I think, a few weeks ahead of you in terms of our experience with the reopening, I think many people anticipate that there's a switch that you flip. You go from living in a bubble, living under your bed, not going anywhere, not seeing anybody, to now it's back to normal. And that's not the way it works. And John, you look like you want to add.
I was just going to reiterate Gail's point. I think it's a very good one, that it's easy to tell people what not to do. It's hard to tell people what they can do, because these are unanswerable questions. You know, it's easy to say, stay home, don't go shopping, let someone else do it, wear a mask, and isolate yourself. But when it's, well, can I see this friend or this relative who's been careful, and we're going to be, you know, in a reasonable way, I mean, yeah, it's probably okay, but you know, you can't really give any kind of a data-driven answer. So it's very tough.
I will say that I think because I think our patients already have a heightened sense of what does it mean for me to protect myself when I'm in the middle of X or I'm in the middle of Y. I think at least in our area, they've done a good job of cocooning themselves and are trying to test the boundaries a little bit, which we can't really give them a lot of guidance on. But I think they're going to test it in a safe way, as opposed to, you know, driving by the one restaurant on Peachtree Street that's got 100 people crammed into a 10 by 10 foot space. That happens, and I'm sure it's going to happen in New York, just like it's happening here. Those tend not to be our patients who are in the middle of that. So I think in general, that at least is somewhat hopeful. Yeah. So why don't we skip a little bit to some of the things you guys are doing to care for folks, and maybe we can compare and contrast a little bit. So, you know, as an example, for all of our surgeries that are occurring, there's a COVID test that occurs pre-op. For all of our transplant admissions, there's a COVID test that occurs within 72 hours. For all of our CAR-Ts, same thing. There's a COVID test that has to occur. Are you guys doing that? What are you doing for regular outpatient treatment? So RCHOP that just comes to the infusion center, spends 2 hours and then leaves. Are you testing for those? Or Gail, for your consolidations that are done as outpatients, how are you all approaching testing in those patients?
We actually had a call on this exact topic this morning, and I can tell you that as with everything, one size fits none. So the answer had been, for all admissions to the hospital are COVID tested. That is still the case. Even if they were tested 3 days ago, they are tested again. With respect to the outpatient department, we've actually just had our statistics literally this morning, and we are seeing, actually, touch wood, very few positives. We are seeing, 4 to 5% positives on the serologies, which is what we were expecting. We all have the cases that we say, oh my God, I totally knew this lady had it back in March and now they're serology positive. So we're seeing those. But what we had decided already in HEMONC so far was that if you are starting, quote unquote, big therapy or new therapy, that you would be tested. And for our patients, the Lukes and some of the transfusion dependent patients, the theory has been that if you are with frequency in the infusion center, and therefore you're coming in contact repeatedly with people, that you would have repeat testing. However, we had arbitrarily said that in the absence of symptoms, we weren't going to do more than once a month or so, because for the massively neutropenic and thrombocytopenic patients, we actually had some concerns about the repeat swabs over and over and over again. So I would say that there is definitely the hospital is hospitalizations, definitely transplant, definitely surgery, definitely pheresis patients have been tested beforehand. I think that in general, for the frequent flyer patients, we are slowing down a little bit, but still planning to continue so that we don't miss any potential to, catch a flare or an outbreak. But I do think that weekly testing, which had been what was originally advocated, probably doesn't make any sense and might for some of the patients actually be clinically not the right thing to do.
John?
No, I would agree. I think that, getting a test for a patient where you have an indication for it has not been a problem for us. If either the patient meets whatever criteria you have, which you can be fairly liberal and still get those patients tested. I think, for me, the biggest difference is that, I get patients all the time who I have some cervical nodes, I may have a scratchy throat, and those are patients that historically I would say will come in and we'll see you and we'll poke around in your neck. And those are patients who we get a COVID test before we tell them to come in, because that's at least in the differential. So, I think patients that, and for new patients, many of these patients will have already had this as part of it because they've got new symptoms, they've got new respiratory complaints as part of their diagnosis, or they've had a procedure and they will, have had it as part of that. So I would agree with what Gail says. And, unlike perhaps the mass screening that is a whole nother level of public health issues and, having like Gail, a parent of college students wondering how colleges are going to deal with this and that infrastructure. I think that's one setting, just like there are others, whether it's sports teams or companies or whatever. But from the standpoint of a new patient coming in or a patient where we need to get a test, it's really not been a problem. And I think our threshold has been pretty low. And frankly, if I don't think of it or if I hadn't done it, I have somebody like an infusion nurse saying, where's the test, or has this person been tested if the person, has any sort of an issue that could be related to COVID or just in general.
So are you, go ahead, Gail.
One of the things that I think is, and I don't know if Carlos has any comments on this, but sort of, people like to have some control over something, right? So the whole fomite transmission, and you have to like wipe your newspaper and dip your fruit in bleach and whatever to try to prevent. So we know COVID can be on surfaces, but we actually fomite transmission of COVID is either non-existent or hasn't been shown that you really, are you going to get infected from touching a newspaper type of thing? So one of the things that I think would actually be useful to know, and I don't really know the answer, so even in clinics for patients, for general recommendations, what are we saying other than good hand washing, which is here forever and ever and should have been here before and is here to stay? But with respect to going into the hospitalized setting, because this is one of the things that patients bring up, that we don't want to go in because we don't want to sit down in the waiting room, or we don't want to touch a doorknob, or if we touch a doorknob, then we have to go through this. So how can we reassure people, or what can we tell them about specifically contact transmission? And does that extend to the New York subway? Does that, I think that's an area which is resulting still in a lot of weird ritual behaviors, first of all, that people are doing, but secondly, that's part of the fear of going into the back into the centers because it's so difficult not to touch stuff. I'll tell you, every single elevator button that we have now has something called NanoSense on it, or some little sticky things that are supposed to magically decontaminate them, and various doorknobs and handles have things that say I think it says NanoSense. It's some antimicrobial technology. But the question is, what do we actually tell people about this? Can you sit down in the waiting room or not?
Oh,
you did, Carlos.
Gail, I think we talked about, the WHO faux pas, and we can talk about the CDC faux pas, right? A couple of weeks ago, CDC said there's no transmission from fomites, and then they said, well, maybe there is, and we didn't really notify people. I think the evidence clearly is that there's not as much transmission probably from fomites in this virus. And I think while I want people to continue washing their hands, I also want to get away from, I think what we need to, two critical things to tell our patients is wash your hands, wash hand sanitizer, and more importantly, don't touch your face. I mean, try to not touch your face. I think those are the key things. Do I need to wipe the paper? No, I've never done it and I never will do it. Do I need to wipe the mail when I bring it to the house? No, I never done it and never will do it. Do I need to, if I get takeout, do I need to wipe it out? No. But after I take the takeout out of the container, I wash my hands and then and then I don't touch my face. So I think washing your hands and not touching your face are things we can tell people. If you get on the subway, if you're touching the handrail in the subway, yes, probably after you do that, you shouldn't touch your eyes and scratch your nose because you're probably gonna, if there's virus, you may get infected. But I think it's less likely than human to human transmission. And I think that's something we can tell people very clearly. Don't worry about where you're sitting, worry about who you're sitting next to and what that person is doing. And I think we need to, I think we're learning more about transmission, that we need to start demystifying this incredible phobia that people have and try to focus more on what really is important.
That's what I was focusing on, the word confusion, right? Because we have to start unpacking this for people. And I actually think that as we look across our patients, it is completely possible that our patients are they're geared up for this. They were neutropenic during the flu season. They know what to watch out for. It's very possible that they saved themselves from this just by their understanding of having a cancer diagnosis and some of the things that they know from the beginning. That's absolutely true. But that doesn't necessarily, even when family members are careful, we have to get the messaging out there. And I think we've worked very hard on this. Don't forget, again, our hospital, epicenter of the epicenter, is fabulous when you're coming up with Nobel Prize winning research. It is not so fabulous when you're in the middle of a pandemic. So we've actually had to explain to people, it is safe to come back in. It's safe. We're doing lots of things to minimize contact. I actually am still in full gear, which the patients, think it's funny because they think it's funny that I'm in scrubs. I'm not a scrubs kind of type, but they like it. They like it that I have a full mask and face shield on, which I do in clinic, which is very uncomfortable. I'm in scrubs. I'm not taking clothing home. I think that there can also be, so on the one hand, we don't want people to be paranoid and doing things that are making their lives difficult. On the other hand, in the environments, healthcare environments, et cetera, to show that we're safeguarding the patients, I think actually is an important message. And I know that in New York, for example, I was speaking with my hairstylist, whom I really need to see actually, and she was telling me, I think the hair salon guidelines are way more than our elective surgery guidelines. I mean, I've never seen anything like it. These businesses that have already been hurt so badly, they have to buy plexiglass dividers. The hairstylists have to have full fluid shields on, plus masks. They have to change their robe between every patient. The guidelines that are being put forward, again, you wonder, is this really smart, or is this just completely financially ruinous, considering that in my own clinic, not everybody is wearing a face shield, and yet if you go to the hair salon, you have to. So this is where we just have to accumulate some information that makes sense for people.
Yeah, but so I think your New York hair salons need to come down to the Georgia tattoo parlors. Any of that is required. Gail, you mentioned something a moment ago that I think is worth touching a little bit on, and that's serology. And so there are actually a couple of questions coming through about serology. So 5%, I would have thought it'd be much higher, actually, given the number of infections you all had in New York, but maybe it's just because the cancer experience is more narrow.
No, wait, this is just in our group of patients. It's much higher than that in New York broadly. It's much higher than that in New York broadly, and I suspect it's going to continue to go up even in our population as we increase the testing. I think a lot of our patients actually may never make antibodies as part of the issue there, and I don't think we fully know the denominator, but no, I think that the numbers in New York, aren't they, like it's like 25 or 27%?
It's around 20%.
Yeah.
I think it's even higher than that at the last numbers, but it's very high. And I think there too, there's confusion because I think patients are reading about the different tests in the newspapers and trying to figure out which company actually did their test, which is not totally easy to find out sometimes. And then some of them are IgG, some of them are both IgG and IgM, some of them offer titers that are quantitative, some don't. So even there's a bit of confusion, but I think, I don't know, do you guys tell your patients that, well, antibodies look like you probably have been exposed. We are hopeful that that confers some level of immunity for some period of time, but we don't know that much about how much you're protected. And actually, I don't know, again, you guys tell me what you're doing, but for our colleagues who are antibody positive, they are continuing to wear PPE and have not changed their personal sort of PPE and other thresholds because they have antibodies. Are you doing the same or different?
Yeah, no, I think we're doing exactly the same. Our frequency is much lower than yours is. I think, Carlos, you know our numbers. I think we're about 5%, 5 to 7%.
Yeah, 5% are positive among. But again, you know, I think what you're saying are two things. I think the antibody tests are all over the map. And as I was telling somebody, it's really right now still a wild, wild west, and we need to maybe get a little more order. But I think when you start looking at some of the very best antibody tests, there was a study recently published that showed that even people with, there was a study they did on sailors in the USS Roosevelt, that a lot of young people there got infected. Many were asymptomatic or had very mild symptoms, yet 90+% of them developed on antibodies, and most of them were neutralizing antibodies. So the good news is even with mild infection, you'll get antibodies, they'll be neutralizing. The question is for how long? So young people are clearly going to develop neutralizing antibodies. They probably won't last very long, but at least will probably prevent them from a second infection in the next year or so. But still, it's still a small percentage of the population. As a nation, we probably have at best, you know, less than 10% of people infected. So when people talk about, for example, you know, oh, we're going to go and have herd immunity and we're going to infect a lot of people, you will need to infect, you know, 260 million Americans to get herd immunity. There's absolutely no way we will survive that. So that's why we really need a vaccine. I think, you know, the number of people infected in cities like New York is big, but it's still in the 25%. It's still not in the 60% or so that you'll need for herd immunity. Having said that, if we get a vaccine with 30% efficacy in New York, you guys are set, because that will give the population of New York the herd immunity they need. It's not going to be the case, you know, here in Atlanta or in other places.
But what do you think about what people, I mean, with respect to testing the efficacy of the vaccine, right? If the number of cases are not at a threshold level, it becomes incrementally more difficult to test the efficacy of the vaccine, right?
Oh, it's going to be incredibly challenging. I think, you know, it's testing a vaccine during a pandemic is really hard. If you recall the Zika pandemic, the same things happened. Once you had the vaccine, the epidemic was gone. The Ebola epidemic was exactly the same. By the time they were getting ready to test the vaccine, the epidemic of 2014 was gone, and they had to wait until the next outbreak to test it. That's why, you know, the vaccine development is going really quickly, because we want to test the vaccine when there is an ongoing transmission. And you know, it's a little bit like almost, I feel really strange. As a public health expert, I want to stop transmission. As a vaccine expert, I wish transmission will continue, because that's what I need to test my vaccine. But I can tell you that transmission is clearly slowing in many places, and it's going to make it really hard to test the vaccine. So we were talking to manufacturers the other day saying, well, maybe we need to have more vaccine testing done in South America, because that's where transmission is happening right now. So chasing the epidemic, I feel a little bit like the surfer who, you know, is trying to chase a nice wave. You got to be there at the right time in the right place. Otherwise, you're going to miss it. And it's going to be tricky, because you may complete your enrollment and you may not have the endpoints you need.
Yeah, and the IFR is not, I mean, thank God, but it's not the astronomical numbers that we thought it was going to be, even with the current cases that are evolving worldwide. So, I mean, I think that all of that, you know, one never wants to say anything about trying to say that this is less severe than we thought, because that sounds minimizing, and this is the nightmare of our lives. but actually it is that. So it didn't turn out to be the apocalypse that we thought it was going to be in the middle of March. And the implications of that, though, with respect to unlocking things and vaccines, and for people who are saying that, well, the only safe time to reopen is when a vaccine efficacy is demonstrated, these are absolutely unrealistic. I mean, this is not a plan, because there's really no expectation that something like that, even optimistically, would be a year from now, and that's assuming a certain caseload.
And again, Gail, what's not said a lot, developing a vaccine that is an immunizing and an immunogenic and sort of a fully preventative vaccine for respiratory viruses is almost unheard of. I mean, we talk a lot about the flu vaccine, you know, it has an efficacy of 40% at best. So.
Exactly.
So what the vaccine manufacturers are looking for is actually a vaccine that prevents disease progression. It doesn't necessarily, is not that good for preventing infection, but is really for preventing disease progression. So really, I mean, the reality is the vaccine may not be one that prevents, you know, infection at all. You will still continue seeing transmission, but hopefully will decrease, you know, progression of disease. And that may be a very different vaccine. We've never had a vaccine that actually did that.
Well, I mean, I just think in terms of the conversations that one is hearing, you know, again, John and I both have college-age kids. My nephew is in kindergarten. You start hearing the conversations from academic institutions, from businesses about what is required. And it's simply not possible. The benchmarks that are being set for, well, we're going to do this when that happens, don't actually make any sense. So there has to be, I think there has to be a little bit of guidance of taking the data that we have in totality, which is very, very far from perfect, but sort of helping people who are not doing this every single day to not come up with lists of absolutely unattainable goals for their businesses or for their, you know, for their schools, whatever they're doing. I got to tell you, I mean, many of the colleges, for example, are in areas that have literally 2 cases in the entire town. There may be an 80-year-old physics professor who may not want to treat a seminar class in close quarters, but that there are different, all of this has to be bespoke. It's got to be different. There is no one size fits all. I think it's the ultimate example of one size fits none. And New York's nightmare is totally different, because we now have a different scenario of having the concentration of all these cases followed now by the specific circumstances of the protests and so forth. This is not translatable everywhere. And I just worry that we're trying to, you know, the decision making that we have here is just not going to be the same for towns across America that have 0 or 1 case.
And it's very difficult to give the advice to patients. And again, I want to go back to what you mentioned. What do we need to do, and what kind of messaging we need to get so patients actually come back to hospitals? I mean, I'm really concerned about people missing their treatments, about, you know, taking risks that are higher than the risk of getting infected, quite frankly.
Yeah, no, I think those are good points, and that's sort of some of the NCI impacts that we've got on this slide here. I want to wrap up the one question, though, about serology. If somebody is serologically positive, are you still testing them if they're in the midst of treatment? And 2, these are questions that have come to us over the Q&A. And 2, we know that often our cancer patients takes longer to clear COVID positivity. So are you holding therapy for the duration of time that they're positive? Or is there a certain point where you say, you know, they've been asymptomatic for 4 weeks, I'm going to go ahead and restart treatment? How are you all handling those?
I think it all depends on the context. It all depends on the context, and you know, if you're in no rush to treat the patient, you're conservative, and if the patient, you know, has an aggressive lymphoma, a growing leukemia, you know, you're going to go ahead and treat and cross your fingers.
But there were some data that were emerging that this kind of reinfection concept, and we all were worried that I had seen what I thought were a few cases of somebody who was positive and then negative and then quote unquote reactivated. The data so far are very limited, but they suggest that that is very, very, very uncommon, and that if anything, you might have had a false negative in between somewhere. I think if you have, you know, if you have a curable patient and you've waited and they're not going back, I think you can strongly consider just retreating them. I think with respect to hospitalization, obviously, if they're positive, they have to go be isolated correctly, and they have to follow all of those precautions. So it matters for regimens that are requiring hospitalization that you be aware of that, and that the floor is prepared, and that everybody has the right PPE, et cetera. But I don't think that for the serology positive patients, again, when people have weird symptoms that we can't explain, we are retesting them for COVID. We're not finding that they have it, but we're still doing that, I think, because probably we have PTSD from what just happened, and we want to make sure that we're not missing a quote unquote reactivation case.
Yeah, no, I think you're right. And I think the serology, while it's nice to sort of get some epi sense of what the frequency is, I don't know that any of us feel comfortable enough to say, oh, you're protected, you've got positive antibodies, don't worry. And so I think, at least in our place, we're dragging our feet on people that are persistently positive, unless, as you all say, you don't really have a choice. You need to sort of make a decision about treatment, or you make a decision about alternative approaches. So go ahead.
Just one final comment on a couple of the positive patients that we did treat. We actually worried that they had more side effects from what we were giving them than we otherwise would have thought. And in a couple of cases, there was one ALL patient in particular who said, and she had really recovered from her COVID. She felt great. She was still positive. This is a potentially curable patient. We proceeded, and every single respiratory and other complaint that she had had when she was actively ill came back. Now, it's hard to know exactly what to make of that, but the patient herself she said, this is exactly what I felt like when I had COVID. So I think you got to be careful, but at the same time, you don't want to lose your opportunity for cure. And if weeks and weeks and weeks are going by and you have no signal that this is changing, you don't want the patient to relapse, and then you're really in trouble.
But I think it also tells you, Gail, that maybe a lot of the symptoms in COVID is not the virus, but is the inflammatory response, is the immune response that is causing the symptoms, right?
And we have, for all of our regimens in my neck of the woods, are highly myelosuppressive. So we have, we've had this clinical sense from the beginning that as counts are recovering, everything just gets worse again. And it's hard to put data behind that, but we certainly have felt anecdotally that, the AML induction was fine. It was when the counts were coming up that the problem started.
Yeah. All right. So let me I've got two more topics I want to cover, and this discussion has really flown by. So the one topic I want to touch on briefly is the sort of quote unquote elective things that we do. And you can define this however you want, because I know most of what we all think we do is not elective, and I certainly would add much of what I do to that as well. But where are you in terms of loosening what a month ago you wouldn't have done, but now you're doing it? So Gail, maybe that fourth cycle of consolidation for you, maybe even the third cycle of consolidation. John, you can pick something that maybe you were holding off on doing 6 weeks ago, but now you're like, all right, let's go.
So I don't want to say that for any of the diseases that I treat that there is a paradigm shift here, because the curable patients need to be getting their curable therapy. And I don't want to be out there saying that some of the substitutions that we made in the height of the pandemic in an effort to limit exposure, et cetera, there isn't a paradigm shift. We don't have that many in my neck of the woods who are curable, and we go for cure. However, I will say that one thing to keep strongly in mind is that the visitor policies are still what they were, and that has, for patients who are very impaired or who are much older or who are patients who would normally be with a visitor attending to them in the hospital, that continues to influence some of our decision making. So I think that's important. And the other thing to think of is that if you can still, for right now, if there are things that you can do for patients who are in a maintenance type of setting, who are perhaps older patients, this would include all the hematologic malignancies where you're trying to prolong remission, but making sure that you're not really dropping their counts too much so that you still keep that interaction with healthcare, that you don't have to check counts twice a week, maybe only once a week or once every 10 days. I still think we're doing that.
Okay, John?
Well, I think there are two parts to this. One, I think, is therapy, and the other is monitoring. I think that therapies, some of our maintenance therapy, maintenance rituximab, I mean, I think we're starting to do a little bit more of that as we come out of things. Clearly, it's not essential. Clearly, the patient's preferences are figuring in. Some are more inclined, some are less inclined, but I think we're starting to do that more. I would say that the other thing about monitoring is, scans, blood tests, physical exam. And I would say that, patients who have a physical complaint or a physical issue on their part are becoming more inclined to come in, as opposed to say, well, it's okay, let's just watch it. A small node somewhere, something like that, in an indolent lymphoma being an example. I do think that people are more worried about their blood tests in our kind of population of lymphoma patients. So a lot of our patients where 3 months ago, as this was starting, 2 to 3 months ago, we would forego a blood test if they weren't having bruising and if their energy was good and they had no symptoms. Now people are starting to say, now we're starting to say, gee, we haven't gotten blood on you in a while, and your blood has been an issue in the past. You have a marginal zone lymphoma that's presented with cytopenias, as an example, and now it'd be good to get a blood test. So I think, we are moving more into doing more of those things, but it's still, I would say, kind of a intermediate position as opposed to a black and white, flip the switch to now doing everything.
Yeah.
One thing that's going to complicate our lives a lot, I'm told, can't wait, is so we've been trying to use a lot of telemedicine. We are trying to optimize telemedicine. And yet there are rumblings that actually many of the guidelines that were kind of waived during the height of the pandemic with respect to crossing state lines and with respect to all kinds of insurance issues that normally would make that difficult are now going to creep back in. And that, I think, actually is going to be a really hard pill for patients to swallow, because as it is, it's incomprehensible as to, well, if I get on a video, then I have a copay, but if she just calls me and tells me the results, then I don't. And I can tell you that people are in our area fleeing the New York area. No joke. Anybody who's got a relative with a house somewhere else, I mean, we are seeing a weird flight that those who are, I wasn't that old in the 70s, but I'm told what happens. And there are a lot of patients who've been counting on it that, oh yeah, she's going to be, Roboz is still going to micromanage my care, but I'm now in somewhere else and all I have to do is get a blood test and see her on a video. So I actually think that's going to be a real challenge to put that toothpaste back in the tube if all of a sudden it's not going to be either legal or covered or feasible from an insurance perspective to deliver those telemedicine visits the way we have.
Yeah, so I want to come back to the telemedicine thing because in just 1 second, let me tell you a little bit, certainly from the myeloma perspective, what we've started doing. From a treatment perspective. So we'd held off on a lot of our early DARA or the frequency of DARA being weekly in the beginning. We've now switched that back. We're now using our bisphosphonates again more frequently. So my guess is, it sounds like from much of the conversation, we're probably 2 or 3 weeks ahead of where you were. We never got nearly as bad as you did. So for us to dig out is not quite as big a challenge, I think, for us as it was for you all. But I do want to revisit the telehealth thing, because I'm struggling with this. A significant fraction of my practice is from out of state, and technically you can't do it unless that state has an agreement, and 3 of our agreements have already expired. And so I think I've heard about the universal license idea that I think will help us, but that's probably a few months away. But the question I want to sort of have us spend a couple of moments on is about, when you have no choice, telemedicine is better than nothing. But I will tell you, except for that well patient visit once a year, I'm not crazy about telemedicine, in the sense that you lose a lot of those intangible things that we as physicians who trained when we trained can pick up when we're sitting in a room with a patient without examining them and without necessarily having labs. And to me, that's a real challenge. I can't pick those things up. And I'm just curious how you guys are doing, because you've been even more full bore than we have into it. I'm not so crazy about it for people that are in the midst of treatment or maybe sick.
Well, we've had labs, so listen, I'm in a lab business, right? Otherwise, I'm talking about the weather because I need labs for all of our patients. And we have gone through, huge jumps and hurdles to make sure that if we have outside labs, that they actually get to us. We've set up remote faxes. We've set up links so that they come into Epic. I mean, really a lot has been done to try to optimize the ability to get outside labs. With respect to safety, I'm not sure whether it's safer for somebody to walk into a commercial lab versus walking into us to get it. But with respect to convenience and also just practical realities of transportation for people during the pandemic, followed ultimately by curfew issues in the Manhattan area, which we're in. I mean, we just had to keep people in far-flung areas home. So they were able to get labs. So you're looking at a patient on a little screen. I don't know how big I am right now, but on a little screen. Half the time the video, the connection is weird or the patient can't quite get it right. The older patients have untold trouble with it and they seem to hate it. So it's not perfect, but it does help. My problem is that a lot of people have, never mind the video, they just want the phone call. And it's, oh, can you just talk to my doctor who's here, tell them what to do, make sure they're doing it right, check on me using the computer. It's great that we have care everywhere, so you can just completely take care of me and give me a call if you see something that you want to change. That's really hard on us, actually. It's really hard to explain that to a patient.
Yeah.
I'm a little more optimistic, and I think that this is going to be an impetus for change. I envision that for some cancer patients, maybe not acute leukemic patients, but for others, I think that the technology and the momentum of this will continue, so that, for instance, patients who get an every 3-week chemotherapy regimen might go home with a packet that is a pulse ox that checks their blood pressure, that checks their temperature, that perhaps can do an EKG, other things, that they'll get a package of these things. They might go to a local lab or have a home blood draw, and we might just see them on the days of their treatment every 3 weeks, as opposed to seeing them mid-cycle. That's not going to work for everyone. It's not going to be perfect, but I suspect that there will be some of these things happening. And when you look at how much point of care ultrasound that hospitalists do, we might even get to a point where some patients get some version of an ultrasound or something. The cardiologists are way ahead of us in this. The diabetic people that manage diabetes with the home monitoring are way ahead of us. And I think in oncology, some element of these things to at least, may not be perfect, but at least kind of push the needle in home monitoring direction more than it is today for some groups of patients, that will make a difference.
Yeah, thanks, John. I think I think you guys have given a great summary, and I still don't think there's any substitute for being able to see a patient in front of you. One of my rules of leadership is, if you don't know for an answer, go to their office, don't call them. And so I think there's something to be said for being there physically.
But you're not the one who has to drive 2 hours and pay for parking and wait in the waiting room, and that's the difference. None of us are.
I hear you. All right, so I think we're towards the end of our time here, so I'm going to give you guys each 30 seconds to sort of wrap up. But what I would ask you now is, what recommendations do you have for patients and caregivers with heme malignancy?
Cure the curable. Cure the curable. Like,
right.
don't skimp on the cure. If you have a curable patient, cure them. And I would argue that this, more than any other time, is bespoke medicine. So really, really find out who's at home with your patient, who lives with them, how are they getting back and forth to the clinic, so that if there are opportunities to micromanage a potential exposure, you can help them with things that make sense, so they don't get caught up with a ton of rules that don't. All right, John?
I think the answer is do the best that you can within reason with all of these situations. I think in cancer care, we try to deliver the best care that we can, but in sometimes we have to compromise. And I think as we approach the COVID epidemic and coming out of this, and what we can and can't do, and what our patients can and can't do, and how we can keep them safe. I think we do the best that we can, and hope that that gets people through it.
All right, Carlos, you're going to tell us it's all going to be okay and we can fly again?
Well, I think it's going to be okay. It's not going to be, when people talk about going to back to normal, I tell people we're going to a new reality, at least for some time. But at the same time, we also need to start trying to create a more normal life. And I think, it's not normal when you have to wear a mask, but I think that's what we need to do for the time being. And I think it's very much in our hands, and we can control things and not get infected. I think we've learned a lot about this disease, and I think we can be careful in certain circumstances. And I think increasingly we're getting more comfortable doing certain things. I mean, would I be ready right now to go to a rock concert with 10,000 people in attendance? Probably not. But am I ready to get together with some friends and have a drink in the backyard? Yeah, I think it's time to do that. And I think we need to think about certain things that are reasonable, and we need to figure out a way to create that social interaction. And the last thing I want to say to patients is don't skip on medical visits. I tell people the safest place to be at today is actually the hospital. So don't skip. We've heard a lot about this transmission in hospitals, but the reality is hospitals are today very safe. It's safe. I feel more safe going to the hospital than going to the grocery store. So I think we need to remind people, come to your clinic appointments. If you need to be in the hospital, be in the hospital, but don't miss hospital care because you're afraid of COVID. That's the wrong thing and can get you in trouble with some more serious disease.
Yeah. Thank you, guys. I appreciate all that. And I guess my parting thoughts would be, use good common sense. None of us have the answers for what you can and can't do, what you shouldn't and shouldn't do. And if anybody tells you they do, they don't have any data. So I think good common sense is probably the best way to go. And I think my colleagues have said it best. So thank you for joining us today, and thank you to all my colleagues for participating. We hope that you come away from this discussion with practical knowledge that you can apply to your practice. Thank you very much, and have a great evening.